So we're going to start with what we call the other studies, some of the other trials. This ASCO, I was actually very impressed. It had a lot of, I thought, very powerful trials for the community oncologists. So Sujit is going to handle the GI cancers, but I'm going to talk about some of the other ones, including some of the myeloma trials and the recur trial and some of the relativity trials. So let's start with the determination. Next slide. So determination tried to answer the question, does early auto stem cell transplant provide benefit for newly diagnosed patients who have received the triplet therapy, RVD, and used lenalidomide until progression? And this was a sister trial to the European trial, the IFM09 or 2009. That was the exact same setup, except in that trial, they only used lenalidomide for 1 year. But we got very similar results from this. So next slide. So this was a multi-center randomized trial, but only done in the US. In this trial, you had to have symptomatic myeloma, and you were randomized to either receive RVD, the triplet, for 2 to 3 cycles, or RVD, the triplet, followed by stem cell transplant with melphalan. Then after the transplant, you get 4 to 5 cycles if you got transplanted, compared to 4 to 8 cycles of RVD, and then both got placed on Revlimid till progression. And the primary endpoint for this was progression-free survival, but they did look at OS, response rates, and duration of response. Next slide. So two of the things I'd like to point out, we've always historically not done a very good job of including minorities in this. And in myeloma, we do see a lot of African Americans have it. But I was happy to say that there are about 20% of people in this trial that were African American that were enrolled in it. And that's the highest percentage of minorities that we've had in myeloma trials. So hopefully we'll get more and more minorities in these trials to make sure that what we're doing works for everybody. The other things to point out is these were predominantly earlier stage 1s and stage 2s. Only about 13% were stage 3s according to the ISS criteria. Next slide. So this is the big slide. It looks at just progression-free survival. And as expected, patients that had an auto transplant had a much longer median PFS, 67 months compared to 46 months, which was historic, about a 21-month overall PFS advantage. And at 5 years, there was still about a 14% advantage. So patients who got a stem cell had a much later progression-free survival. Next slide. This is just a subgroup analysis looking who got the most benefit. Again, patients got, almost everybody received benefit when they got the stem cell transplant. But the biggest benefit was in earlier stage cancers, probably because there just weren't enough late stage ISS cancers to notice it. But also those with standard risk tended to do slightly better than those with high risk, and that's not that unsurprising. Next slide. Somewhat disappointing though is the OS. The OS is almost exactly the same, with the 5-year OS of the stem cell transplant group of being 80.7 and 79.2. Well, you might ask, well, didn't those patients then get rescued with stem cell transplant down the road? Actually, in this trial, only 28% of patients that did not get stem cell transplant up front ended up getting stem cell transplant. So even though they did not get stem cell transplant, there was still a long benefit and the same survival benefit. And that's probably because of these the monoclonal antibodies, CAR T, everything else that's coming out in the future. So these patients are just living longer, but there's no overall survival benefit. Next slide. This is just looking at duration of responses. As expected, those with stem cell transplant had a much longer duration of response in both the PR and also a CR, although the CR did not meet statistical significance. So really the best duration of response was in the partial response group. And again, it was at 56% compared to a 39% response rates. They also looked at the duration of lenalidomide exposure. In the trial, you started off at 10 milligrams for the first 4 months, and you could increase it to 15 milligrams if you're doing well with it. and they found out that duration of lenalidomide exposure greater than 10 milligrams, meaning you're able to get to 15 milligrams, was about 87% in the BRD group alone and only 60% in the stem cell transplant group. Again, not super surprising. These people tend to have more sensitive marrows after a transplant. Next slide. So were there new safety signals? Of course, anybody that gets transplants is going to have more hematologic toxicities, going to have more episodes of febrile neutropenia, mucositis, and recurrent infections. So none of this was super surprising. The good news is most of these toxicities wore off after about 4 months post-transplant. There was also some concern that quality of life, and again, 4 months around the stem cell transplant, quality of life was decreased, but that did improve and mirrored the RVD alone 4 months post-transplant. Next slide. You know, one of the worries about stem cell transplant is increased secondary malignancies, and there was a slight increase of AML and MDS in the stem cell transplant group. Overall, the incidence of secondary malignancies was the same, but again, if you look at the subgroup analysis, there were 10 cases of AML, MDS in the stem cell transplant group. Next slide. So I think in summary, it does show that when used with the triplet RVD, an early auto stem cell transplant does significantly improve the progression-free survival compared to RVD alone, followed by lenalidomide maintenance. However, there was no real true benefit in overall survival. So what this tells me is stem cell transplant is still an option, but it should really be used in a specific patient population. This trial did not demonstrate the exact patient population it should be used for, but there's clearly a progression-free survival benefit for it. And if you were able to figure out the exact subtype, you might be able to figure out an overall benefit for it as it right now. But right now, I'll tell you, this trial I think was almost identical to the trial they had in Europe. Like I said, the IFM 2009. This did have a higher PFS, but probably because both arms got lenalidomide to progression. And that's the last slide, go on. So again, the addition of early stem cell transplant does provide benefit and can be considered a treatment option for very select patients. The heightened toxicities with the addition of stem cell transplant should be used to help patient selection, but also they tend to be reversed after a while. And we do need to be mindful of the potential for secondary malignancies. Next slide. So sticking with the myeloma category, we're going to go on to the ATLAS trial. The ATLAS trial looked at the benefit of triplet maintenance therapy with carfilzomib, lenalidomide, and dexamethasone compared to lenalidomide alone after a stem cell transplant. Next slide. So this was an interesting trial design, and I'll speak a little about that in just a second. People were randomized to get a stem cell transplant, and then you're either randomized to the triplet combination or the single agent combination. But those patients who had standard risk multiple myeloma that had the transplant, after 6 cycles, if they were in an MRD negativity, they would get 2 additional cycles of the triplet and then progress to lenalidomide alone. So when you look at cycles 9 through 36 here, the top number are those that either did not reach MRD negativity or were high risk, versus the lenalidomide alone arm, which is those who reached MRD negativity or standard risk. And that's being compared to the lenalidomide alone arm. So next slide. So this is just the baseline characteristics. As many trials, slightly younger than most of our myeloma patients, but otherwise balanced pretty well. Again, this was the induction regimen they use is not standard in the US. They either use VTD or VCD. So again, it does skew what we use in the US, which is VRD a little bit. Next slide. As expected, as we've always seen in myeloma, the more drugs you use, either induction or in maintenance, we tend to see a better progression-free survival. That's exactly what we see with this. A 59-month overall progression-free survival compared to a 41-month progression-free survival. Next slide. Again, here's just a quick subgroup analysis. Again, just like the last slide, the most patients that benefit from it were the earlier stage, stage 1, stage 2. It was somewhat surprising that the stage 3s did not seem to benefit from it, because we tend to think of the PIs being effective in the higher risk patient groups. But for the stage 3s, it was not effective. Next slide. This looks at the predefined efficacy in these MID-directed adaptive maintenance. And to me, I think this is where myeloma is heading, and we're not there yet. But the key to me is, if you're able to get these people in an MRD, can you drop some of these more toxic medicines? Do you have to do triplet therapy to completion in order to get a better PFS? And so they were looking at this. They had the PFS with the standard risk versus the MRD negative standard risk patients. And in both arms, even when you were to drop the triplet, there is still a PFS advantage. Go ahead, next slide. Unfortunately, just like we saw in the last slide, there is no OS advantage, even though we're seeing a progression-free survival advantage. Next slide. Overall, there were slightly more infections in the KRD arm. I was a little surprised, because we all fear these cardiovascular events with the carfilzomib. There was not more cardiovascular AEs reported. At least grade 3 AEs are high reported in this group. There was one treatment-related death, and the treatment-related secondary malignancies were the same. Next slide. So at this interim analysis of PRD post auto stem cell transplant, there was an improvement in progression-free survival compared to lenalidomide maintenance alone. We are hopeful that this MRD-directed risk-adapted maintenance might be more effective than lenalidomide maintenance alone. And all grade toxicities in each arm were pretty comparable. And so I was happy to see that there wasn't a significant increase in toxicities, even though we added carfilzomib to the maintenance regimen. Next slide. Next slide. So the RECUR trial was also a plenary session trial. The RECUR trial was looking at, it was actually, and we'll talk about it a little bit, it was a multi-drug, multi-phase trial looking at actually 4 different drug combinations, trying to figure out what is the best drug for patients with recurrent or primary refractory Ewing sarcoma. Believe it or not, there's never been a randomized phase trial looking at what's the best second-line patients for recurrent or primary refractory Ewing sarcoma. So this trial actually started back in 2014. Go ahead. As we know, Ewing sarcoma is a rare disease. And so I like this, it's called the drop a loser type of randomized trial. Again, it's a multi-arm, multi-stage trial that initially had 4 different chemotherapy arms. When the first 2 arms would get dropped, it turned from a phase 2 trial to a phase 3 trial. And that's what's been reported right here. So in 2018, it was proven that while Gemzar docetaxel was used, it was probably the least effective of the 4 arms. Then in 2020, irinotecan and temozolomide was also dropped. And so the 2 winners were then topotecan and cyclophosphamide versus high-dose ifosfamide alone, with the primary endpoint being event-free survival. But they also looked at a secondary endpoint of overall survival and toxicities. Next slide. So as expected, there's a predominance of males. These tend to be younger patients with ages anywhere between 4 to 49. And the question was, have they had a previous cyclophosphamide or ifosfamide? The answer is yes, a lot of them have had it previously. Of these patients, the majority were first recurrence less than 2 years since their completion of therapy. But we did have about anywhere between 15 to 20% of patients that were primary refractory. and about another 16% of people that were second-line recurrence of not. Unfortunately for Ewing sarcoma, once it recurs, the 1-year overall survival rate's somewhere about 15%, so not very good. So this was an important trial trying to figure out what is the best second-line regimen. Next slide. So here are the two big endpoints of primary event-free survival. They looked at TC compared to high-dose ifosfamide. And there are very few events in both arms, which is a good thing. But the median overall survival was 5.7 months compared to 3.5 months. So still, the median overall survival is not great in this patient population. But the thought leaders are certainly going to use high-dose ifosfamide in the future as a backbone to any comparison trial in the future. The HR ratio is pretty impressive, even though the overall survival is only about 1.8 months. Next slide. So of note, who is it more beneficial in for event-free survival? The biggest benefit people got were young children under the age of 14. Those over 14 did get a little bit of benefit, but again, the biggest benefit for the young kids under 14. Next slide. So we saw an event-free survival advantage. But what about median OS? This is where high-dose ifosfamide really excelled, with the median OS about 15.4 months compared to 10.5 months. Again, with a pretty impressive HR ratio of 0.73 and a 1-year overall survival of about 55%. Next slide. Again, in the OS group, the biggest benefit was seen in children 14 years and younger. Next slide. Well, what do we all worry about with ifosfamide? You know, infections, encephalopathy, and kidney problems. And there, of course, were higher incidences of those. About 8% of patients got some form of a neurosymptom disorder, mainly encephalopathy. And there was 3% of kidney injury, raised kidney function, proteinuria. So we know the toxicities of high-dose ifosfamide, and none of this, I think, was very surprising. The only thing that was a little surprising was a very high treatment discontinuation rate due to toxicity. Almost a quarter of people that got put on it had to come off it for various reasons, mainly due to CNS toxicity, but also due to myelosuppression, febrile neutropenia, or other renal or tubular toxicities. Next slide. So in summary, this is the first randomized trial comparing different chemotherapy regimens in patients that have recurrent or primary refractory sarcomas. And it did show that high-dose ifosfamide was both more effective in event-free survival and overall survival compared to the comparison arms. Next slide. So I think the summary slide is high-dose ifosfamide does show benefit and will probably be used as a backbone for arms going forward. Of note, they did just say recently they're going to incorporate a carboretopicide arm under this trial. So the recur trial is going to keep going on. They're also going to add a TKI on to the backbone of ifosfamide to see if that can give benefit as well. Next up is an update on the Echelon-1 trial. I think most of us know and have heard about Echelon-1, which asked the question, does the first-line addition of brentuximab vedotin plus chemotherapy improve overall survival in patients with stage 3, stage 4 classic Hodgkin lymphoma? So this is just an update on that analysis, and I'll point out why we're talking about it. Next slide. As most of us know, this was a randomized phase 3 trial that compared ABVD to A plus ABD, and then these patients were followed up. Next slide. So the baseline characteristics are, I think we all know these, predominantly these were stage 4 patients. A lot of them had an IPS of 2 to 3. And the PET negativity status talked about how with the PET adaptive approach, most of them were PET negative. Next slide. So the reason we're talking about this is we now have actually overall survival data. Before, all that was presented was progression-free survival data. So there's now overall survival data, and after 6 years, A plus ABD has about a 4.5% overall survival advantage compared to ABVD. And this is the first trial in 40 years that has shown an OS advantage in first-line Hodgkin's. Next slide. And so they looked at different, again, subgroup analysis with the overall survival. Now, interestingly enough, even though the line crosses the confidence interval, for whatever reason, there was not as much benefit in IPS 0 to 1 patients. And there was also a question of ineffectiveness in those with 0 extranodal sites. Next slide. Next slide. Here's an updated PFS, again, at 6 years. The PFS advantage is about 9%. And this is a median follow-up about 73 months. So more than 6 years of follow-up. Next slide. There were no new safety signals with the prolonged follow-up. You know, what was interesting to me is the majority of people that did progress ended up getting brentuximab vedotin anyways, either as monotherapy or some combination therapy down the road. So next slide. So it was very impressive to get OS, even though they got this drug later on. You know, secondary malignancies is something that people worry about. Very happy to say that there were no new secondary malignancy signals seen in the A plus ABD arm, and it was actually less than compared to the traditional ABVD arm, specifically less T cell and B cell lymphomas. And so, as we know, we do use this medication, et cetera, to treat T cell lymphomas as well. Next slide. Two other high-level follow-up events were the concern about peripheral neuropathy. We all worry about peripheral neuropathy, especially with A plus ABD. Happy to say that the incidence, the grade 1, grade 2, grade 3, grade 4, are just minimally different with the A plus ABD arm. Majority of follow-up were grade 1 and grade 2 events. But more importantly, fertility, while not formally assessed during the trial, they did send out a questionnaire where they asked either the patient or the patient partners. They tried to figure out, could these patients or with their partners, could they become pregnant? Very happy to say that there were 191 pregnancies that have been reported. And there's reported in both the A plus ABD and the ABVD arm, although slightly more in the A plus ABD. So the numbers are so small, we can't say any difference at all, but at least we can say is there are pregnancies that can occur post-treatment. Next slide. Just in summary, after 6 years of follow-up, it's very exciting to say that there has been an overall survival advantage, despite the rate of brentuximab vedotin being used post-treatment, meaning once they recur. And there were fewer secondary malignancies, although did not make statistical significance. Next slide. So the impact slide is the addition of brentuximab vedotin to ABD does provide lasting clinical benefit, including overall survival in previously treated patients with classic Hodgkin's lymphoma, and should be considered as a first-line treatment for these patients. Next slide. We're going to talk about relativity real quickly. So relativity 047 answer the question, does relatlimab plus nivolumab versus nivo alone in the first-line setting provide benefit for patients with advanced melanoma? You might have heard this published in March of this past year. For those of you who didn't, this was a global randomized phase 2, phase 3 trial that looked at patients that had been previously untreated with metastatic melanoma. And they're randomized 1-to-1 to be treated with Rela plus Nivo versus Nivo alone. The primary endpoint was progression-free survival by blind investigator review. And key endpoints were, secondary endpoints were overall survival. Next slide. So baseline, everything was balanced pretty well. Age of patients very similar. ECOG performance status is very good. There were not super high-risk patients, meaning they didn't have multiple patients that had high LDH ranges at all. And they're able to look at the median treatment burden, meaning how much millimeters complete size did it have, and pretty balanced, about 59 millimeters or so, about 6 centimeters total. They did have some patients that had acral melanoma and also some patients that had mucosal melanoma. They also randomized the patients beforehand to LAG-3 expression, PD-1 expression, and BRAF mutation status. Next slide. So here's the biggest slide, that the primary endpoint, which is progression-free survival. There was an improvement of more than 5.5 months in progression-free survival in patients that treated with the doublet compared to nivolumab by itself, with a hazard ratio of 0.75. And if you look out 2 years, we still see that progression-free benefit. Next slide. So they looked at this, particularly looking at, did something help predict the responsiveness to it? Believe it or not, LAG-3 was unimportant. Most of these patients express LAG-3 anyways, but the amount of LAG-3 did not tend to predict responses. Neither was BRAF mutation status. So if you're a wild type or whether you're a mutant, both responded about the same. Next slide. You know, one of the worries that we saw in Checkmate 067 with the Nivi Yervoy arm is the significant increase in grade 3, grade 4 toxicities, which is about 55%. When combined with this LAG-3 inhibitor, Nivo did not tend to have as many grade 3, grade 4 toxicities. So it tends to be better tolerated. Of the grade 3, grade 4 events that we're seeing, about 10% came off trial. There's about 20% in the Ipi-Nivo arm. But we also saw fatigue, rash, arthralgias, and diarrhea as a grade 3, grade 4 events. And we compare to Nivo by itself, everything except discontinuation rates, things were very, very similar. Next slide. Safety features, you know, we look at these immune-related itises, hypothyroiditis, colitis, hepatitis, adrenalitis, pneumonitis, hypophysitis, very similar between the two arms. Next slide. So in summary, Rela plus Nivo significantly improves PFS. Efficacy, including OS and OR, favored Rela plus Nivo versus Nivo alone, although the median OS has not been reached in the Rela-Nivo groups. We're hopeful that this will actually have an OS advantage. And we did feel that the side effect profile for Rela plus Nivo is very comparable to Nivo alone. Although the biggest one that was a 21 versus 11% versus, again, 45 to 50% in the, if you just look at cross trial comparisons to the Ipi-Nivo comparison arm. Next slide. So Checkmate 067 is a trial I was talking about before. It looked at Ipi-Nivo in combination. So here are just some cross trials comparisons. So obviously Checkmate 067 has been around a lot longer, so it's a lot longer follow-up. And there has been OS advantage that has been seen now. So we do not see OS advantage in relativity patients. The other thing in the relativity trial, there were no patients that had brain mets. So we can't use this in patients that had a brain mets. There was probably a slight increased response rate when used with Ipi-Nivo, but certainly a lot higher grade 3, grade 4 toxicities. Next slide. So in summary, I think dual checkpoint with Rela-Nivo does provide PFS benefit and should be used as an option in people only getting single agent Nivo. Last little bit. So I'm going to finish up because I'm about out of time with just Skyscraper 2. Next slide. So Skyscraper 2 was a hopeful trial for me because it looked at the addition of a anti-TIGIT antibody, Tira plus Atezo, in combination with carboplatin and etoposide in first-line setting in patients that had extensive stage small cell lung cancer. Next slide. So in this trial, again, they looked at patients that had treated or patients that had asymptomatic brain mets, and they were given carboplatin etoposide for 4 cycles and atezo Q3 weeks been placed on atezo maintenance, and they were randomized to either tira or placebo alone. And then if you got on the maintenance with tira, you continued the tira indefinitely. The co-primary endpoints were OS and also PFS. Next slide. Unfortunately, this was a negative trial. There was no true OS or PFS advantage seen with the addition of this anti-TIGIT antibody. And this was a little disappointing because the phase 2 trials have shown some efficacy in this. I think this just goes to point out that while we all like phase 2 trials, the phase 3 trials are the gold standard. And sometimes we get excited about these newer immunotherapies, and we need these phase 3 trials to show what's beneficial. This is just the secondary endpoints, again, looking at PFS, OS, again, not much benefit anywhere except for maybe a slight increase in overall response rates. Next slide. So again, we don't like to talk about too many negative trials, but it is important to talk about them. The addition of tira to atezo in combination with carboplatin and etoposide did not provide any benefit at all. And that is it for me. I'll pass it on to you, Sajid. Or, what questions do we have?
Yeah, Eric, that was great. A lot of stuff there, as we alluded to. So there was one that Sujit answered, but there's one that's up right now. So feel free to look at that one. But Sujit, I think this one would be good because it's what we do here, which is talking about how this information applies to the community setting. So where the question was, the determination trial is hard for me to interpret in my practice because I often use a different maintenance and have also started incorporating quad strategy. So Sujit gave a response, but I think it would be a good forum just to talk about just in general, what are your thoughts on that? Sujit, feel free to comment on what you applied to that question as well.
Yeah, I mean, Joel, I think if you look at the NCCN guidelines, they still recommend triplet therapy first pre-transplant. So while more and more people are beginning to do quads, and I've done quads before, I don't know how this quad regimen will determine it. And you're right, some people are even using the monoclonal antibodies in maintenance right now. So myeloma has been this always almost ever evolving field. By the time of the trials complete, there are newer medicines out there. So I guess the way I would use this is I still, half the time I use quads, half the time I use triplets. I base it on the patient's performance status, their age, and kind of the aggressiveness of their disease. Meaning patients with Q1 minus that are very high risk, I'll probably do quads and get them to transplanter soon. So that's kind of how I decided to do it. But you're right, I can't take the data from the determination and say, hey, listen, I'm going to use, DARA maintenance plus these medicines and say better, worse, or the same. I just can't do it.
Great. Sujit?
No, I agree. I think it's an evolving field, and people use, if you look at the NCCN guidelines for multiple myeloma, it probably has the highest number of regimens in any disease because they've practically placed every regimen out there because they realize that this is a complex situation, and patients, when there are successive lines of treatment, will recycle everything.
Yeah, and this is one a disease where there's a lot of interest from the multiple companies looking at NK cell therapies, autologous or allogeneic NK cell therapies, because myeloma, essentially a lot of different things work, and if something can be found without cytokine release syndrome or the toxicities of a full transplant, it could be another addition to the long list of things that you've already mentioned.